Hi, so in this video, we'll be looking at ERAS, which refers to Enhanced Recovery After Surgery. So, ERAS, they are a group of evidence-based perioperative practices which helps in the early recovery of patients who are undergoing major surgery. So the entire concept of ERAS is based on the metabolic response to injury. So if you have not watched that video, I would recommend you watch that video first and then understand what ERAS is and why we follow ERAS. So the main aim of ERAS is to reduce the surgical stress, maintain normal physiological function, and to enhance early mobilization after surgery. So since we improve the recovery or we try to bring about early recovery of the patients, the benefits of ERAS would be one, obviously, reduced hospital stay, decreased cost of the patients. Obviously, since the hospital stay is reduced, the recovery is early. So the cost will also be reduced. There is increased patient satisfaction. So first, let us look at what are the components of ERAS. As we have seen that it is a group of perioperative practices. Perioperative meaning pre, intra, and post-operative practices. So we'll understand ERAS in a little more detail. Okay, so the pre-operative components would be firstly patient education and counseling. I'll explain all these in a little more detail once I enumerate all of the points. So we have patient education and counseling, carbohydrate loading, avoid prolonged fasting, avoid bowel preparation, nausea and vomiting prophylaxis, and thromboprophylaxis. The components of intraoperative management would be zero fluid balance, minimally invasive surgery, avoid drains, maintaining normothermia, multimodal pain management, regional anesthesia, and using short-acting anesthetics. Next, the components of post-operative management would be early mobilization, early enteral feed, avoid NG tubes, early Foley's removal, again zero fluid balance, pain management, and nausea and vomiting prophylaxis. So coming to the preoperative management, patient education is very important when it comes to the preoperative management in ERAS, as you need to explain to the patient the details of the surgical procedure, explain post-operative pulmonary physiotherapy, the importance of early mobilization and early oral intake, the preoperative information such as avoiding alcohol and smoking at least a month prior to the operative procedure, managing the medical comorbidities. And next, coming to carbohydrate loading. Carbohydrate loading is done in a bid to prevent the depletion of glycogen storage. So this is important because once glycogen stores are depleted, it leads to insulin resistance and hyperglycemia, which, as we have seen in the previous video, leads to post-operative complications, morbidity, and increased surgical site infections. Okay, next, coming on to avoiding prolonged fasting. The rationale behind this is that it was found that patients with prolonged fasting retained a higher amount of gastric contents when compared with patients who were allowed to drink water prior to surgery. So, American Society of Anesthesiologists suggest 2 hours for liquids and 6 hours for solid foods. Avoid bowel prep. So, earlier bowel prep was done with the idea that getting rid of solid fecal content would reduce the bacterial load. But mechanical bowel preparation liquefies your solid feces, which increases the risk of intraoperative spillage of contaminant and thereby can lead to increased risk of infections. Next, coming on to the intraoperative management, zero fluid balance. So, one thing to note is that both hyper and hypovolemia are detrimental. So, hypervolemia leads to increased morbidity, the length of ICU stay, and postoperative mortality. And hypovolemia, on the other hand, would reduce cardiac output and decrease tissue perfusion. So, middle ground needs to be found between these two, and that is the zero fluid balance. When following ERAS, it is usually observed that the patient would have post-op hypotension and decreased urinary output for the first 24 hours, but that is not due to renal dysfunction. So, next, coming on to minimally invasive surgery. Minimally invasive surgery would lead to lesser pain and hence earlier recovery. Avoiding drains. So, drains increase the length of hospital stay as well as can become a source of infection, and hence avoiding drains can lead to earlier recovery. Normothermia. Maintaining normothermia is important as hypothermia will lead to shivering, which increases the oxygen requirement and thereby contributes to a catabolic stage. Second, hypothermia also leads to coagulopathy and increased risk of arrhythmias. So how do we maintain normothermia? Normothermia can be maintained by using warm saline, heating mattresses, and there are other circulating garment systems which can be used. Multimodal pain management. When it comes to pain management, one thing to be noted is that we need to limit the use of opioids as it prolongs the post-operative ileus and leads to delayed recovery, and hence use of non-steroidal anti-inflammatory drugs. And the WHO pain ladder should be followed. Also, regional anesthesia, as we have discussed in the previous lecture, prevents the excitation of the nociceptive neurons and thereby can prevent the neuroendocrine response which occurs to the noxious or painful stimulus. Next, coming on to the post-operative management, early mobilization, early enteral feed brings the physiological status of the patient back to the baseline and hence would help in earlier recovery. Preventing nasogastric tubes are helpful as one, it reduces the risk of aspiration pneumonitis. Second, it reduces the post-operative ileus. Early Foley's removal, again, to bring the patient back to the physiological state. Zero fluid balance, the rationale is same as the intraoperative management. Pain management, again, the same as the intraoperative management. So we've seen in this ERAS that this is a multi-management team, not done by surgeons alone. So the team members that are required for successful enhanced recovery programs would be nurses, dietitians, your physiotherapists, would be the surgeons, of course, would be the anesthetists, would be the pain team, occupational therapists, the hospital management. It is a multimodal team. I would like to show an image from Bailey and Love, which emphasizes the early recovery when following an ERAS intervention. So here we see that post-surgery, the functional capacity of the patient would be reduced to a lesser extent and for a lesser period of time when following ERAS intervention. However, when following traditional care, we see that the recovery would be delayed. So the entire premise of following ERAS is again based on the metabolic response to injury. So summarizing once again, ERAS are a group of evidence-based practices involving a multidisciplinary team with emphasis on pre, intra, and post-operative management of the patients. with emphasis on early recovery and early discharge. Thank you so much for watching this video. If this video was helpful to you and helped you understand ERAS a little better, do hit the like button. Please subscribe and share this video. Thank you so much.